Good evening, everyone. I'm really pleased to welcome you this evening at the event of the MEP's Interest Group on Access. On behalf of the Patient Access Partnership and all partners, I would like to welcome our honored co-chairs of the Access Interest Group and also the speakers that we will have tonight on so interesting topics. I would like to send the apologies of Mr. Kovatchev, who will be joining us a bit later today, but he will join the meeting and continue with it. Before we go to the topic today, I want to share with you very fast and shortly an outcome of the latest event of the Patient Access Partnership, a conference in Sofia, regional conference with the regional stakeholders using the model of PACT but at local level, and hopefully we can have a video now. Is the video working now or it's not? Okay. But we don't have a sound, I think.
Трябва да мине през най-малкото изследване на възможността за партньорство. Независимо дали в рамките на това партньорство интересите съвпадат или не. Но когато промените и целите на тези промени са ясни, то партньорството става смисъл и за двете страни. По време на председателството на България през 2018 година основен приоритет в сферата на здравеопазването на България ще бъде лекарствената политика и достъпа до качествено лечение на европейските граждани.
По-добрият достъп води до по-добри здравни резултати, а те подобряват не само индивидуалното благоденствие, но и това на обществото като цяло. Когато се радваме на добро здраве, сме и по-продуктивни и по-малко, разбира се, разходи за здравеопазване.
like to thank you, the Bulgarian government, under which auspices and financial help this conference happened. A copy of the full report is available at the exit, so take a copy so you can see some of the outcomes of the conference, recommendations, and everything that the people in those 25 countries think about access and healthcare. Now I'm pleased to give the floor to the two of the co-chairs of the interest group on access. But before that, we are really happy that we have a new co-chair joining the interest group on access. This is Mrs. Wierinck, and she, with her coming on board, the palitra of political parties in co-chairing the Access Partnership becomes fuller, which shows that access to healthcare doesn't have color. It's something that considers all of us as citizens of Europe, and we are really happy to welcome her here today. Please.
Ladies and gentlemen, it's my pleasure to welcome you to today's meeting on the interest group of access to healthcare. During the next 2 hours, we will talk about the state of health in the EU and in the 2016 Health at a Glance report that was published last week by the OECD. First of all, I would like to excuse my colleague, Mr. Kovatchev, who will be arriving a little bit later due to train delays. But he will join us as soon as he can. He also asked me to do the honors and open today's meeting. I will happily do so by saying that I am a strong believer of our European cooperation on health matters, and I believe that we can still find a lot of benefits from taking this cooperation to the next level. We all know that the Commission is doing whatever it can within the limited possibilities of the treaty. I will be a strong supporter of the Commission in every initiative it takes to strengthen the cooperation between Member States, and I believe that the state of health in the EU is a very good example of what can be done in this regard. It is clear that we are in challenging times where we have to make tough decisions. Budgetary pressures demand that we make clear choices, and I don't think today is an easy time to be healthcare minister. At the same time, we need decisive action. The aging population is pushing up healthcare spending. At the same time, we need to rethink our healthcare system and the way we look at the spending. At the moment, I sometimes feel we are operating a sickness system rather than a healthcare system. There is not enough focus on prevention, screening and early diagnosis, while these measures should be looked at as investments, not as costs to be borne. Technology is also reaching us a helping hand. The opportunities from mHealth and eHealth are enormous, and it's up to us to get the systems in the place to reap these benefits. But going into that discussion would lead us too far. I have the pleasure to present our two excellent speakers for today. First of all, we will have Mr. Martin SEYCHELL, Deputy Director General at DG SANTE, and after this presentation, we will listen to Monsieur Gaetan LAFORTUNE, Senior Economist at the OECD. Afterwards, I count on all of you to have a lively discussion. Thank you.
Thank you very much, and we are really happy to have Ms. Kadenbach here as well. And before we go to the very scientific and specific part, Ms. Kadenbach, you have some words to welcome the participants?
Well, yes, just to say that I'm very happy that we have a new colleague on the board, new co-chair, that the room is so full of interested people, so I dedicate the time I have, my time slot, to the discussion afterwards. Thank you. Hear from you later.
Thank you very much. Good evening, and first of all, a sincere thanks for hosting us today and also for having this discussion on a very important topic. This is indeed an important period for us in the Commission, and particularly for us in DG SANTE, as regards knowledge building. And if you will allow me, I'd like to first of all give the context of our work and explain to you briefly what it means. In President Juncker's November 2014 mission letter, Commissioner Andriukaitis was asked to develop, and I quote, expertise on performance assessments of health systems to build up country-specific and cross-country knowledge which can inform policies at national and European level. As you are all well aware, Member States are indeed responsible for the definition of health policy and for the organization and delivery of health services and medical care. There are, of course, many specificities and different contexts, and these correspond to a wide variation in health systems and indeed in public health across the EU. But that is one side of the coin. There are, of course, also common challenges. And one common challenge, certainly, is that all health systems across the EU, to a greater or lesser extent, are under unprecedented pressure to evolve, to modernize, and to adapt to an ever-changing environment, be it because of new technological developments, changing epidemiology, financial constraints, or patient engagement. So that is the overall context. And in the face of all this, and in response to our Commissioner's mission letter, DG SANTE has strengthened its country-specific and cross-country knowledge and its network of knowledge brokerage in the field of public health and health systems. As you know, the European semester is one of the prime channels for country analysis, and the Commission has just published this year's annual growth survey, which sets the priorities for the 2017 semester. Effective, accessible, and resilient health systems are explicitly mentioned in the annual growth survey, both when it comes to responsible fiscal policies and also in terms of social protection. Meanwhile, DG SANTE's contribution to the next year's country reports is already in full swing, and I am very pleased to note that the role of health in economic governance is increasingly acknowledged, and not just the fiscal sustainability in the strict sense of the term, but also quality of care and accessibility of the system are being increasingly recognized. But of course, the European semester is only the tip of the iceberg for the country analysis in our case. We very much believe that beneath that should be a solid foundation of reliable information and of knowledge that we can draw upon for many different purposes and on many different occasions. And this means partnering up with internationally renowned experts in the field, such as the OECD and the Observatory for Health Systems and Policies. The OECD in particular brings extremely valuable internationally organized expertise to our work, and the Commission has, of course, a long-standing and successful cooperation with OECD on health-related issues. The report, which has just been launched, is a good example of this cooperation. But we have many others, such as cooperation to support Member States' efforts to optimize health workforce development and planning, cooperation on the economics of prevention, including studies on obesity and alcohol, and OECD support of the Commission's expert group on health system performance assessment. Just last week, DG SANTE and OECD strengthened their collaboration further by identifying a limited set of midterm priorities in a new cooperation arrangement. This cooperation arrangement identifies three priority areas. The first priority is to strengthen the knowledge of health systems and their performance, including through country-specific analysis. And this priority refers to the State of Health in the EU initiative, which I will elaborate on in a few minutes. The second priority is to help countries make their health systems more people-centered, including by developing new, internationally standardized and comparable measures of experiences and outcomes, the so-called patient-reported experience measurements and patient-reported outcome measurements. This should lead to the establishment of the patient-reported indicator survey, which will extend and accelerate international collaboration in the standardization, collection, and analysis of patient-reported experiences and outcome measurements. The upcoming OECD Health Ministerial meeting of 17 January 2017 is expected to put this topic high on the agenda of the health work of the OECD for the years to come. And the Commission and OECD are very keen to closely collaborate in this area. The third and final priority of our cooperation is to develop capacity for economic analysis of public health and health systems, notably in the areas of public health, prevention of chronic diseases, and innovation. Key areas on which the cooperation will focus include antimicrobial resistance and access to innovative pharmaceuticals. The key guiding principle for our cooperation in all these issues is the imperative of maximizing the value of our work to the benefit of our member states, of course, in full respect of our mandates and institutional frameworks. We will therefore seek to leverage joint activities to support EU and OECD countries' capacity to improve health systems and policy making in the health sector. The Health at a Glance Europe report, which we are presenting to you today, belongs to the first and foremost priority of our cooperation arrangement. It is the first product of the state of health in the EU cycle. This report has been prepared by the OECD in cooperation with the Commission and supported by the Health Programme. And the report has been aligned to the three objectives of the 2014 communication on the effectiveness, accessibility and resilience of health systems. The report covers the most recent trends on health and health systems across member states and includes the most recently available comparative data. Its findings clearly indicate the need to put healthcare at the center of our policy debates and demonstrate many opportunities for future health policies in Europe. In addition, the report also discusses a number of issues. I'll just highlight a few. The economic costs and labour market impacts of chronic disease and related risk factors, with premature deaths among working-age adults leading to an annual loss to the EU economy of approximately 115 billion euros. The strengthening of the primary care sector, with focus on access and quality of primary care, highlighting the need to focus more on prevention and management of chronic conditions outside hospital care and before these conditions deteriorate to the point of requiring acute care. The big difference in this year's edition of Health at a Glance Europe is, as I said now, it's part of the Commission's State of Health in the EU cycle, and this was already highlighted. But what exactly is this initiative? As I've mentioned earlier, strengthening evidence-based policy making is now more important and crucial than ever, both to rationalize public expenditure but also to ensure the effectiveness, accessibility and resilience of health systems. An exchange of best practice is, we feel, really important and crucial in an area where there are so many different policy options and where there are persistent budgetary and other resource constraints. The main role of the Commission is to support Member States in their evidence-based policy making and to promote the organisation of best practice exchange through, indeed, this instrument. It will also help the Commission to reveal further needs for evidence and areas where EU added value is particularly meaningful. The State of Health in the EU cycle is a recurring two-year series of analytical products on country-specific and cross-country knowledge in the field of health. It is supported financially by the Health Programme, and through it the Commission brings together internationally recognized expertise and provides Member States with evidence relevant to their specific context without judging on their comparative performance. The State of Health on the EU builds on the renewed synergetic partnership between the Commission, the OECD and the European Observatory on Health Systems and Policies. It is conducted in full transparency with Member States and, I would like to emphasize, will not impose any additional administrative requirements or reporting obligations on Member States. Furthermore, through an inter-service group, the State of Health in the EU will build on the pooled expertise generated by other Commission products, such as, for instance, the recent Commission Economic Policy Committee joint report on healthcare and long-term care systems and fiscal sustainability. The Health at a Glance Europe 2016 is the very first product of this cycle. And the report, as well as the rest of the cycle indeed, is linked to the policy framework introduced in the 2014 communication. I would like to give you very briefly some examples of what these concepts mean and how the respective findings link to the Commission's wider agenda. Firstly, the effectiveness of our health systems. The report is confirming what we already know. the burden of chronic diseases and the behavioral risk factors associated with them, such as smoking, harmful alcohol use, and unhealthy diets, is huge, with a substantial impact on health, social systems, and the labor market. More worryingly, the report shows that obesity rates have increased by 50% over the past 15 years, suggesting that without timely and effective action, the prevalence of chronic diseases will increase further in the coming years. Member States have committed to reach the WHO targets on non-communicable diseases by 2025, but it is very clear that at the current rate of progress, very few Member States, if any, will be able to reach them. The state of health in the EU is an instrument which will help us identify where our actions could be more effective to overcome challenges identified. Mutual learning is also very important. While 250,000 people die of colorectal and breast cancer in the EU each year, screening rates are only marginally over 60% among high-risk populations. But the report shows that some Member States manage to screen 3 times as many people as other Member States, suggesting that significant improvements are indeed possible. The state of health in the EU, and in particular the country health profiles which will be produced next year, will help us in identifying and discussing such good practices, and there are many examples. Better monitoring exercises and new data development are also crucial in this context. Here we can think about health system performance assessment, but also about the new patient outcomes and experience measurements that I mentioned earlier. The Commission and OECD are very keen to closely collaborate in this area. The second dimension is the accessibility of our health systems. I recognize this is indeed a topic of interest for many participants present here today. The report highlights that access to healthcare remains unequal and inequitable in the EU. And the Commission has been engaging with different stakeholders on a debate on how to improve access to healthcare, and is currently developing projects to improve its measurement. Measurement is a precondition for understanding and for indeed improving access. And our aim must remain to help improve access to people, particularly from disadvantaged groups. The importance of improving access to healthcare has been recognized by the Commission. Timely access to good quality healthcare for everyone is one of the 20 principles proposed by the European Commission for a European Pillar of Social Rights, which is under public consultation until the end of this year. It is also increasingly recognized in the European semester. This approach, I would emphasize, is also in line with the global agenda, as universal health coverage has been identified as a precondition for achieving the Sustainable Development Goals adopted by world leaders in 2015. But accessibility is not only a noble principle. The state of health in the EU will clearly illustrate how accessibility is fundamentally interlinked with other parameters such as effectiveness and resilience. For instance, providing timely access to good quality care to everyone is also essential for sustainability of health systems. Patients with low access to basic health care, such as preventive services, will increasingly use acute or emergency care, which is far more expensive. Overall, this is not only more expensive, but also less efficient. And health systems that are accessible are therefore also contributing to both social cohesion and to fiscal sustainability. The third and final dimension, also very important, is the resilience of our health systems. EU economies continue to experience low growth rates. We cannot afford increases in health expenditure at the same rate as the increase in demand for healthcare caused by population aging and worsening risk factors. But there is still a lot of potential for easy gains in improving value for money in our health systems, and Health in a Glance points out the potential for many of these. For example, there are 9-fold differences between countries in the use of chemically identical generic drugs in place of branded products, suggesting scope for marked savings in many member states. However, to keep up with increasing demand for health services, we also need to radically rethink how we provide healthcare. When we say health systems, we must stop picturing the hospital as the predominant form of healthcare provision. Our only chance to continue to improve the health of our populations and even more importantly, to do so in a financially sustainable way, is through a holistic approach with a strong emphasis on patient-centered primary and integrated care as well as on prevention. Let's be very clear. Intervening at the most appropriate time in the disease pathway is the only way forward, is the only way in which we can achieve all these objectives. It is certainly much better for patients and can lead to important savings. And the new Health at a Glance Europe report and the subsequent deliverables of the state of health in the EU cycle will, we strongly believe, guide member states through this process, pointing out best practices and showing what gains are achievable when they catch up with their peers. The remainder of the cycle of state of health in the EU will provide the complementary country-specific information that is required to enable a more comprehensive exchange of best practice that takes into account the specific context of each and every member state. The second component of the cycle, foreseen for November 2017, will be a set of 28 individual country health profiles, which will be developed also by the OECD and the Observatory in cooperation with the Commission. These will be expert-driven analytical documents which will provide complementary data and indicators and emphasize the particular challenges and characteristics of each member state. The Commission, the OECD and the Observatory are about to conclude an extensive internal pilot phase for next year's country health profiles. The objective of the internal pilot phase has been to test the format, presentation and scope of the profiles, which will balance on the one hand a standard template and set of core indicators, with on the other hand a more tailor-made country-specific approach that takes into account the particular context of each member state. These country health profiles will also be accompanied in November of next year by a Commission analysis, which will be the third component of the cycle. This factual analytical paper will put at the service of member states a succinct overview of the profiles, as well as an assessment of a small but focused number of cross-cutting topics that link to common health policy priorities across the EU and reveal potential for EU added value. The fourth and final component of the cycle, which will start as soon as the profiles and Commission paper are published, will be the opportunity for an exchange of best practice that member states can request, if they so wish, to discuss concrete aspects of their respective situation. And these exchanges with the Commission, the OECD and the Observatory will be done on the basis of the findings of the cycle and will help member states to use the gathered evidence if they wish to do so. Of course, even without this, I am confident that member states will also find ways of using this information also for their own national policy making, and we are also happy to support that in any way. So this brings me to the end of my intervention. My colleague Gaetan LAFORTUNE from the OECD will elaborate on some of the key findings, which I'm sure you'll find very interesting, and I would be happy after that to take any questions or respond to any requests for clarification on other purposes. Thank you very much.
Okay, thank you very much. Good afternoon, everyone. I'm going to essentially repeat what Martin said, but showing it in through a graphic way. So, providing a bit more information on where countries, how well countries do on different indicators. Can I do, just at the beginning of this intervention, can I do a quick survey with you just to, if you are familiar with Health at a Glance Europe, can you raise your hand so that I know how much I need to provide in terms of information? Okay, so that's, I would say that's a vast majority. But still, I'll have to spend a bit of time for the sizable minority. Okay, I need to do, is there a PowerPoint flicker? Or because if I don't have any PowerPoint, then you're not going to see any graph. Sorry. Okay, well, I'm delighted. I will only have the time to present, and I'm glad that many of you are familiar with the presentation, because I'm not planning to go through all of the publication. It would take an hour or two, and that would be way too long. What I'm planning to do, if the technology works, is to go through some of the topics that we're dealing with. We have a very rich chapter. Like, this is the 4th edition of Health at a Glance Europe. And I'm a bit biased on this, but I would say that this is the most, the best edition so far, the richest in terms of the topics that we covered, and also in terms of some of the topics on which we're focusing on that Martin talked about. Next slide, please. Okay, this is, the screens are a bit smaller than what I expected anyway. Okay, I'll go over this one very quickly. This one just relates, like, it shows like that we all need to keep in mind that the health system and the health expenditure and the doctors, like, only affect part of people's health status. Like, often there's a sort of a simplistic view that health spending or healthcare system, like, are the main driver of the illness and the life expectancy of people. Like, the most important determinants of life expectancy are all the non-healthcare factors. So it relates to how, like, people live, their living conditions, their working conditions, the physical environment, the pollution, and all this. And then it relates also to like their lifestyle. So whether or not they smoke, whether or not they drink too much alcohol, what they eat, how much physical activity they do. So that's the main thing. So we all need to keep this in mind. But when we are sick, like, we do need a healthcare system that will take care of us. So that's very crucial also. And the health system performance, you need to assess it in terms of access to high quality care in relation to costs. So that's what we cover in the publication. I'll spend a bit of time in the next few slides going through the access issues, given the interest of this group. So I'll spend quite a bit of time on this. I'll spend a bit of time also on reviewing the health expenditure trends, and then, but before that, I'll go into the box on the right side, which is the lifestyle factors, and what are the trends in terms of the risk factors to health. Next slide, please. Okay, first on health status, I'll go over this quickly. So some of the indicators of life expectancy and health inequalities, and then one of the consequences of the rising life expectancy, which is that we are already having a growing number of people that have one or more chronic diseases, and we can expect that this population will grow in the future. Next slide, please. This is this shows the trends in life expectancy over the past 25 years. Across the EU, like, life expectancy has increased by over 6 years over the past 25 years. The good news is that it has increased everywhere. And the bad news is that the gap between the countries with the highest life expectancy, which are like in these charts, like all the EU 28 countries are shown on the left-hand side, and then the EFTA countries and the candidate countries are shown on the right-hand side. But the gap between the countries with the highest life expectancy and the lowest life expectancy is about 8 to 9 years, and it goes like from the west part of Europe to the east part of Europe. Next slide, please. There's also inequalities in life expectancy across within countries. And life expectancy at birth, it can be by income level, by education level, or other socioeconomic marker. Here we're showing some data on education level at age 65. What is not shown here at birth, between the life expectancy of people with the lowest level of education compared with the highest level of education is 7 years at birth. At 65, it's a bit shorter. But here also we see that there are that the inequalities vary across countries, and it is much bigger in the east part of Europe. So, and in particular among men, and this relates obviously to some of the risk factors and unhealthy behaviors. Next slide, please. This is showing the fact that the number of people who are living with chronic diseases has already increased due to population aging. This focuses only on the number of people living with dementia by age group. Can you click on the next slide, please? It shows the trend between 1995 to 2015. Next slide. And this is what we can expect 20 years from now. in 2035. So there will be more and more people living with dementia, including possibly ourselves. So we should not exclude ourselves from this in the coming decades. So we need health systems and long-term care systems need to think very hard about already. It's not like if it's a new thing. This and other chronic conditions have been with us for a while already, but we have to rethink about how we're going to organize the health and long-term care services about this growing number of people. Next slide, please. I'll go. So one of the messages is that there needs to be a greater focus on prevention, but already that was in the, was glad to hear that in the introductory comment from the chairperson, to address these risk factors and to promote more healthy aging. Next slide. Spending on prevention represents only 3% of the total health spending on average across EU countries. There's a bit of a variation, but most of the spending goes to treat people when they are sick. So a greater emphasis on prevention may be more effective and more cost effective in keeping people healthy. Next slide, please. Smoking. Okay, I'll go through some of the most important risk factors to health, and there's nothing new there. Smoking is the riskiest thing you can do to damage your own health. The good news is that it has come down in all EU countries, but still, there's more than 20%, more than 1/5 of adults in the EU smoke every day. There's still some way to go to reduce this further, particularly in countries that are on the right side of this graph, and to move more closely to achieve the lower smoking rates of the countries on the left-hand side through a mix of policies. Obviously, there's no single magic bullet to address tobacco smoking like other risk factors, but through comprehensive and sustained strategies. Next slide, please. Alcohol consumption, a big problem in many countries, particularly among men, but also among women. This shows data from the last European Health Interview Survey from 2014. So it shows regular heavy drinking, and what it shows is also that there's more than 20% of adults who report themselves that they are drinking heavily. This is defined as people drinking more than 6 glasses of alcohol in one occasion at least once a month during the past year. So another risk factors that need to be addressed among adults and among children also. Next slide, please. Boy, this one will be difficult to see, but anyway, the main thing to see is that it's the obesity rate, and it's obesity rates among adults, and it is steadily rising in all countries. And I just found out that Martin is from Malta, so I don't want to embarrass you too much, Martin, by showing this chart for too long. But Malta is not doing too great, but all countries should be concerned. And obviously, if you want to deal with obesity, you need a mix of a strategy that will address the nutrition equation and the physical activity part of the problem. Next slide. This is showing obesity among overweight and obesity among children. And this is the same story as for adults. So obviously, the children of today are the adults of tomorrow. And there's a greater risk. If you have weight problems when you're young, when you're a child or adolescent, you have a greater risk of having weight problems when you reach adulthood. Next slide, please. Okay, so that completes the part on risk factors. Then I'm going to talk about some of the trends in health spending and financing, and so we'll go a bit closer into the access issues. If we look very generally, one of the main indicator in terms of health spending is just to relate it to the size of the economy. And health is a major, represent a significant part of EU economies, about 10% on average in EU countries, 11% or more in the countries on the left side, so Germany, Sweden, and France. Much less in countries on the right part, Romania, Latvia, and about 5 to 6%. And So this is very important to keep this in mind, these variations in health spending as a share of GDP or on a per capita basis, because it also explains why some countries are doing better in terms of access and quality, and why some countries are not doing so well, and may need to spend a bit more to achieve their access and quality objectives. Next slide, please. This shows the trend, like what has happened after the economic crisis, and in terms of health spending. And so health spending, in terms of the EU average, health spending went down and went negative. Like it was not only zero growth, but it was negative growth, like in the years after the economic crisis. Then it has started to pick up in the neighborhood of 1 or 2%. But obviously, next slide, this hides a lot of variations across countries. This shows the growth rate before the economic crisis, and the health spending was growing at a fairly rapid rate in many countries before the economic crisis, up to 2009. Next slide, please. But then when the economic crisis hit, like the countries that were particularly hard hit by the crisis, on the left-hand side of the graph, Greece, obviously, but also Portugal, Croatia, Cyprus, Italy. Like this shows the annual growth or negative growth in health spending since 2009. So you have to in Greece, we're talking about a reduction of 30% in health spending between 2009 and 2015. Portugal a bit less in the area of 10%. Like if you add up all the years after years. So there has been a major slowdown or reduction in health spending, both on the public side and on the private side. Next slide. This shows how the different spending categories were growing before the economic crisis. So it shows, like, it's a bit hard to see, I guess. I'm sorry for this. It shows the hospital in the first category, the outpatient, the long-term care, pharmaceuticals. Prevention spending is the second to last, and then administration. Next slide. But then it shows what has happened. Like all the spending categories were hit when the crisis hit, but some spending categories were more hit than others. And the pharmaceuticals spending came down. This was a result of a couple of things, of deliberate policies to reduce pharmaceutical costs, notably through the promotion of generics, as Martin alluded to. But then there was also like a coincidence of many blockbuster drugs losing their patents, so it made more drugs into the generic domain. And then prevention is also one of the first part that is cut when there are tight budget constraints, and we saw this also after the economic crisis. Next slide. Oh boy, sorry for that one. I'll go very quickly through this one. This shows the financing of health spending. Like the main messages is that on average across the EU, like more than 3/4 of health spending is publicly financed, and about 15% is paid directly out of pocket by people, with the remaining being mainly private health insurance. And but then there's a lot of variation also across countries. Like obviously, like all the EU averages, like hides the diversity across countries. And there is in countries like Cyprus, Bulgaria, Greece, Latvia, like it's the part which is paid directly out of pocket by patient represent 40 to 50% of the total. So this is the part that can create obviously financial barriers to healthcare. Next slide. And this shows that the out-of-pocket spending increased more rapidly, like in terms of than the public spending. The public spending was virtually zero growth on average across EU countries after the crisis, while the small growth that has happened in the spending was in the out-of-pocket. Next slide. Okay, so access to care. I'm assuming that this is the main topic of interest to you, so I'll spend a bit of time hoping that you're able to see what's on the screen. I'll go through health coverage first. Most EU countries have achieved universal coverage for health care, meaning that all the populations are covered for a certain set of health services and goods. There are some exceptions, which are the countries at the towards the bottom of countries that still have a way to go, like Cyprus, Romania, Greece, and Bulgaria. Like there's still about 10% or more of the population that is not covered. This doesn't mean that if, like, the people in these countries, like, are ill or get hit by a car and they go to the emergency department and the hospital, they will not receive treatment. But this means that they don't have a regular health insurance coverage, which may limit, like, proper primary care and good access to care. Next slide. This next slide comes from the European Union Survey of Income and Living Conditions. You may be familiar with this. It shows the unmet care needs for medical care or dental care. And what it shows is that the poor people in all countries are more likely to report unmet needs for medical care and dental care than rich people. Like it's like this is expected. This is not a big surprise. The gap is particularly large in some countries, the countries at the top. And I'm just going to name a few, not to embarrass them, but just to show that access issues are particularly important in Latvia, Greece, Romania, Italy. And in terms of medical care, there's even greater access problem in terms of dental care, because in most EU countries, dental care is not as well covered. Like, will be covered 50% or less than 50% than of the cost. So there's more there's more unmet need, and this can be unmet need either for financial reasons, for geographic reasons. So it's people who are saying, okay, I cannot have my medical examination or my dental examination because there's not a doctor or a dentist nearby, or because of waiting times, because people have to wait too long, like to get services. If we look at what has happened after the economic crisis, next slide, please. So we see that unmet needs, this is focusing on financial reasons, showing unmet needs for the total population. Then for the lowest income group, the poor people, and the highest income group, we see that before the crisis, the unmet need was coming down. But after the crisis, it either stabilized or started to increase, like particularly for dental care. Next slide. Now, if we look at the workforce, which is important, of course, to get effective access, like it's good to have like a sort of a financial and theoretical access to care. Whoop, can you go back? Yeah. What we see is that the number of doctors, like this is probably contrary to conventional wisdom, because the talk is always that there are shortages of doctors in every country. But the number of doctors on a per capita basis has increased in nearly all EU countries since 2000. And it has increased on average by about 20%. Like this doesn't mean that there's no shortage, because if the demand has increased by more than 20%, perhaps this increased number of doctors who are working is not sufficient. Next slide. But then the composition of the medical workforce has changed. There are less and less general practitioners, fewer general specialists, and more specialists for a number of reasons. First, for financial reasons, because the salary gap between general practitioners and medical specialists has increased in many countries, so it has made general practice less attractive. And there's also the issue of the sort of the working conditions of general practitioners, particularly if they work in solo practice. It may be quite constraining in terms of a way of working time. So that's a very major issue in many countries if you want to ensure proper access to primary care for the whole population. Next slide, please. There's also a persisting issue that there's the number of doctors varies quite a bit between different regions within each country. So in French, like the term that is used is the déserts médicaux, so medical desert, so areas where there are very few or no doctors. This slide shows in particular what, like the sort of the fact that doctors often tend to concentrate in national capital region. That's particularly the case for specialists, where most of this specialist services and where most of often the training hospitals will be. But there's wide variation. So often, like the shortages of doctors relate to shortages of GPs and shortages of GPs working in outside the major urban centers. So, and that's a very crucial issue in many countries. Next slide. The number of nurses has also increased. So we often hear also about the shortage of nurses, and this doesn't mean that there's no shortage of nurses, but there have been an increase in the number of nurses working in nearly all EU countries, with only a few exceptions. Next slide. This is a slide that you will not see in the presentation, but that I have borrowed from one of our partners, the European Observatory. And it's a 4 quadrants chart which compares the relative number of doctors with the relative number of nurses. And in the top right corner, you see the countries that have more than the EU average of doctors and more than the EU average of nurses. And these are all countries in the west part of Europe that are spending a lot on health. Then in the bottom left corner, you have countries that are spending in the eastern part of Europe that have fewer doctors, fewer nurses, and are spending much less on health. And then you have countries where there's in the 2 other quadrants where there are more nurses, more doctors than the average, fewer nurses, which may reflect a different division of labor between doctors and nurses and vice versa. Next slide, please. And now, an issue of access also relates to waiting times. And there can be different types of waiting times of health services. You may have to wait if you're sick in the morning and want to get an appointment with a doctor. You may have to wait to get a specialist appointment if your GP refers you to a specialist. This relates to waiting times. What we show in the publication is waiting time for planned surgery. And here is the example of a hip replacement. Hip replacement, like there are a lot of hip replacement and a growing number of hip replacement related obviously to population aging. And what it shows is that there are huge variations across, like we don't have complete data from all countries, like this is coming from administrative data, but there are huge variations across countries in how long people have to wait between the time that their specialist says that you need a hip replacement and the time that they get it. It's quite low in the Netherlands, very high in countries like Poland and in Estonia. If you look at the trends over time, it was sort of coming down in many countries up until the budget constraints hit really hard on many countries. But since then, it has either stabilized or it has started to increase slightly in some countries. Next slide, please. So the conclusions of some of the conclusions, like it would be too long to conclude everything from this presentation, and I invite you to read it if you haven't read it yet. But some of the conclusion is that there's a need to focus more on health promotion and disease prevention, both among children and adults, in order to reduce the demand for health care. There's a need to strengthen primary care and patient-centered care for people with chronic diseases to manage better these conditions outside hospital. There's a need also to reduce any financial or geographic barriers to health care and to ensure timely access to services. And the last point is that there's also a need to improve the efficiency of health spending, because the demand will keep on increasing. The resources, we can probably not expect the growth rate in health spending to grow at the same rate as they were increasing before the economic crisis. The budget constraints will remain. So there is a need to make sure that the money is well spent. Thank you very much.
Thank you very much, our speakers, for the very interesting discussion. Hopefully we will have. but really for the very good explanation you both gave. I will give the word to our coordinator.
Thank you very much for the very interesting presentation and initiative. Now we will open actually the debate here with the stakeholders in this room to see some first reflections and questions you might have. But before I give you the floor, I actually have two questions here which I do consider quite important. During the Sofia conference, which was focusing on several countries with the local stakeholders, one of the debates was how the local stakeholders, the local doctors, patients, nurses, local pharmaceutical industry can get involved and contribute to such important EU mechanisms as the EU semester, providing data and providing more information so the country-specific reports are more close to the reality. Because we have some research showing that depending who you are, you might have different opinion for exactly the same topic, if you're the doctor, if you're the government, if you're the patient, etc. In this regard, I think it's also very interesting to know that in future there would be country profiles developed. How can we make sure that when preparing the country profiles, the stakeholders in these countries would be properly consulted and probably could be very helpful to provide more full picture for the country reports? This is my first question to both of you, and how actually the Patient Access Partnership could support this process locally through the countries. The second question, when we talk about universal coverage, we saw that many of the countries had achieved universal coverage in terms of covering the majority of the population. But when it comes to range of services, the baskets, are they comparable? And if the people are 100% covered, but for very small or limited services and number of services provided by the system, do we still talk about universal healthcare coverage in this case? And shouldn't we looking also into this element of universality? Thank you very much.
Yes, maybe I'll take both questions, of course. First of all, on the local involvement, this is indeed key. This is fundamental also in our thinking. We certainly don't believe in producing evidence for the sake of producing an encyclopedia of health. That's not the aim. The aim is that this evidence base, which is really, we believe, the best possible and strongest based evidence base we could together with our partners in the OECD Observatory, should help stimulate a discussion at national level, of course, because that's where the decisions have to be taken primarily, of course. But we are perfectly prepared to support this process if member states so wish. But even if it's done at purely national level, we believe there is a great need to have this discussion. Health is really important for citizens, and I think a discussion on health is also an excellent way for national administrations to connect and also face some difficult situations together with their citizens. I mean, we have seen that the demand for healthcare is increasing faster than we are able to provide. And this requires, I think, a very strong discussion with the stakeholders. And by stakeholders, I think everyone is interested in this. So our hope and our idea is that this evidence base, which we are presenting in a way which is user-friendly, which is trying to be as presentable as possible, that the issues are brought out as clearly as possible, should serve ultimately to stimulate this national discussion, dialogue. And here I think stakeholders at the national level, at the local level, have a great role to play. Of course, we are prepared to support the process. I mentioned before that the fourth and final element in the cycle is the possibility. It's a possibility. It's up to member states to decide to have this national discussion, this policy dialogue, we call it, and that can take many forms. It's up to member states to decide how they want to do it. But we would strongly recommend this because I think this is an excellent topic where people have a lot to say. And I think they should be able to say it. On the second question, the issue of coverage. This is indeed, of course, there are many elements of this. One could argue, for example, if services are offered, and it's of course up to member states, because every health system will have its limitations. No health system on the planet can offer every possible treatment or every possible intervention. There's always going to be some limitation. But of course, one dimension is if something is offered, is it accessible, available to everyone? That's one dimension. Then, of course, there are the issue of unmet needs. What is not offered? We saw the example of dental care. Now, one thing to keep in mind is that, of course, unmet needs, and there are many, don't go away. They don't disappear just because the needs are unmet. Very often they come back through another door. So we might say, for example, that this treatment is not offered. But I think the question we have to increasingly ask is, what is the optimum intervention stage? Because if people are excluded from access at one particular point, it may turn out that they might re-enter the health system at a more expensive point. And so I think this discussion, of course, then it's a matter of choice, but we should be a conscious choice. It should not be dictated by, kind of knee-jerk reactions. And of course, taking into account opportunity cost, what we overspend in one area will lead to underspending in another area, because there's always going to be a limitation. This is the reality of life. But as much as possible, we believe that evidence can help at least reduce, if not completely take away, but reduce the uncertainty in these discussions.
Yeah, if I may, I'll respond quickly to the two questions. They're very interesting. First, for Health at a Glance Europe, like the first step in the state of health in the EU, like we are working very closely with countries already to produce this publication. Like it's not like if we invent these data, either at the OECD or in Eurostat or at WHO. Like we collect the data from the countries, and then the countries have an opportunity also to review a draft of the publication before it is published, like people in the ministries of health. So we are providing this opportunity. And so the plan for the country, obviously, like Health at a Glance is a cross-country, provides cross-country comparison. So it cannot go as deep as the country health profiles will go. But as we go into the deeper into each countries, then obviously it will become very important to also get the views of countries. But it has to be like a sort of what we're providing, I think, is an independent view. Like in one sense, like you will have like in some countries when we release Health at a Glance, like they are uncomfortable because like we're showing that, okay, like country, I'm not going to name any country here, but if you push me really hard, I can name a few. But anyway, on antibiotic, okay, antibiotic, like it's clear that there's too much antibiotic consumption in some countries, so you can look at the publication and you will see which country I'm talking about. But but we don't need a lot of convincing on this one. So, but there is some sensitivity, but it has to be a sort of an independent assessment of the strengths and weaknesses, keeping in mind also that if you are going to measure health system performance, you need to keep in mind how much countries are spending, because you cannot expect. Like I'm thinking about the countries in the east part of Europe. Like and many of the countries there probably have to spend more, like on a per capita basis and as a share of GDP, because like or health, like it will be very difficult to provide access to high quality care, to keep the doctors and nurses from moving away to other parts of Europe if the spending is not increased. We realize that that it may need some negotiation with ministries of finance and so on. On the second point, which is on universal health coverage, very important. What you said, like the sort of you want all the population to be covered, but then like the next question, the first question is who is covered? Is everyone covered? Then the next question is what is covered and how much is covered, and so that's you have to assess accessibility based on this. But then keeping this in mind and picking up on what Martin said. Like countries will need to make tough decisions. There are trade-offs. Like some countries, and here I'm going to name one country, like Denmark, like has decided that it would have free access to healthcare. So no co-payment if you go see your doctor, no co-payment if you go to hospital. But on the other hand, for dental care, for pharmaceuticals, like it is much less covered. So there is a trade-off between the how much is covered with like the sort of the breadth of what is covered and how deep you can cover it, like whether you can cover 100%, because you will not be able to cover 100% of healthcare, dental care, pharmaceuticals, long-term care, like unless like your citizens are agreed to be taxed at the rate that are probably unachievable.
Thank you. Actually, your answers encourage the patient access partnership. Because in our plan, we are considering for next year to pilot series of local debates on healthcare in several countries, particularly focusing on the European semester, the country-specific reports, but why not also including somehow stakeholders debate together with the countries and helping you preparing your reports for the countries, because I believe the view of the stakeholders, those people who live, work in those countries, use every day the systems in those countries, would be extremely helpful for you preparing really independent view of the situation in this country. With this, I would like to open now the floor for questions coming from the people in the room. Oh, yeah?
I would like to come in where you just left with the country-specific recommendations on the semester. I'm also a member of the committee that's budgetary control, and we do have the recommendations from the Court of Auditors. And usually the public can read what the countries or whatever institution is audited answers. Do we get the possibility, if a country gets country-specific recommendations during the semester on health issues, what their answers are? Is there some kind of, let's say, like some kind of an audit? Is there a mentoring afterwards? Is there something that we can really follow up, what they do with this information, what they do with those recommendations? Or are you just going to write every year and again, tell them that they should spend more on, that would be my question, actually. I know that the recommendations on health are rather young, but I think it probably follows the same principle as recommendations in other fields.
I think we have to keep in mind the European semester is a very specific process which is not designed primarily to improve health outcomes. Of course, it takes strongly into account health, because health is a big element, an important element of public expenditure, and also because health is a factor, an economic and social factor. Right? And this is increasingly being recognized. So whereas in the, let's say, early iterations of the process, the main emphasis was on identifying inefficiency and waste and optimizing the supply of healthcare, now I think there is a growing emphasis also to looking at the demand. So that's a process, but we have to give it, it's not designed primarily to optimize the health system, which is why this process is very much a separate process, which of course will contribute to the European semester. One should also not overestimate the recommendations, the country-specific recommendations on health that are given in the European semester, because of course, they have to be of sometimes rather general. I mean, it's a process of more interest is to look at the country reports, basically, which go into far greater depth. We would like to go broader and deeper on health, because this is now, the state of health is a health-related cycle. Of course, it will contribute, and we believe should contribute to the European semester, but also to a lot of other processes, in particular the national processes, because this is where the bulk of the decisions on health will continue, of course, to be taken. This is where they need to be taken. And on the kind of difficult choices, the trade-offs that have just been mentioned. Of course, it would not be realistic to expect the European semester to go into that kind of detail. No? But it's important that other processes, national processes, address these issues, and that Europe supports these processes. We cannot just say member states are on their own. Here our role is to support. So we believe that through this regular cycle, we will have the opportunity not to give hundreds of recommendations. Because if you ask member states to address hundreds of issues, it's a guarantee that nothing can be done. So we have to be very targeted and focused, work together. There will be a process where we identify, and we have a lot of structures in Europe, possibilities to use instruments, because this is another issue. One reason for doing this at European level is because Europe has instruments that it can offer the member states. So it's not just a diagnosis. We do have powerful financial tools that can be used. We have policy instruments that can be used. We have possibilities to use networks that exist to identify areas where it makes sense for member states to work together, like we're already doing on health system performance assessment, HTA, e-health issues. So really, I would really argue that what needs to be done is to ensure that this evidence base is then followed up through being taken on board by the national decision-making bodies with the support of EU structures, if that's what member states feel is appropriate.
Thank you. I already saw a few hands in the room. We start with Susanna, and then we go here for the question. Please say who you are and which organization you represent.
Good evening. My name is Susanna Palkonen. I am representing today EFA, European Federation of Allergy and Airways Diseases Patients Associations, representing people with allergy, asthma, and COPD. First of all, thank you very much for the presentation of this interesting report, and it certainly gives the echo of what we find from our member associations on what is happening in our disease areas in terms of healthcare and so on. I would like to ask a few questions regarding the prevention side of things that you described, because sometimes we are using the word lifestyle, and sometimes we are using the word risk factors. But from patients' perspective, these are very, very different things, because the other one is putting the focus on the individual, that you are smoking, you are drinking alcohol, and the risk factors is putting it to the more of the system level, that you cannot necessarily influence yourself. It's true that our societies today, we have the kind of food industries we have poverty, we have advertising, and smoking is an addiction. So I would like some clarity, and I would plead for use of a terminology that is completely precise on these two elements. And then I would like to also know, when you are saying about the expenditure on prevention, what is included in prevention? Because I suspect that this is only about promotion campaigns or vaccination campaigns, whereas for us, prevention is health in all policies and all of this integrated. So that's a precise question. And then the final is about something like rehabilitation. It's true that this is not part of the formal healthcare, but if we are talking about sustainability of healthcare systems, things like that have a very big impact, not to mention to the healthcare system expenditure, but also to the patients' lives. So sorry for being long.
Yeah, it was a long question, but I think all of them very important. Shall we pick up a few more and then you can answer? Yes, please.
Yes. Good afternoon. My name is Tanja Valentin from MedTech Europe. I share some reflections from the views of all 4 healthcare industry partners of the PACT Alliance, which is actually the generic medicines, the medical technologies, and the innovative medicines. So thank you for this report. It was a lot of information, and it's an eye-opening diagnosis of the health situation, and I think you gave also clear recommendations, which probably the whole room will share. In this respect to what to do, we would like to stress 3 points which we think are very important. First, there's the need to reform the healthcare systems to shift from the fee-for-service to the outcome-based, patient-centric care, as you already outlined. So we see a high variation of health outcomes in the healthcare intervention today, and that is due to different clinical practice, different uptake of health technologies, and different care pathways. So we believe that we can redesign our care pathways, giving more value for patients and the systems through, for example, standardized collection of outcome data, also understand better what kind of outcome data we are producing across healthcare system. Another aspect would also be to have full transparency about outcome data, because we think that can, without regulation, facilitate a positive race to the top and improve patient choice. And we see also some member states, especially in the north of Europe, applying outcome-based thinking have already remarkable results, which is very encouraging of what this thinking is promising. The second area is the need for better integration of healthcare vertically across primary, secondary, and tertiary care. And you already mentioned the link that primary care is most at risk, as well as horizontally, including the hospital, long-term care, and social care. Also there's a lot of opportunities. The third one is the need to consider healthy population as an investment rather than a cost, which is outlined in the new chapter. I think that is a remarkable novelty of the report, to look at economic value of the healthcare population beyond the healthcare ecosystem, and factoring in elements like absence of work or retirement or limited productivity if people are suffer from disability. And these factors itself have a significant effect on public pension systems, health insurance funds, and social security schemes. So the effects are huge. And seeing then health as an investment rather than a cost is an important conclusion and the right direction of thinking. So what can be done? We believe both European semester process and the state of health are excellent platforms to support this decision making. So from an industry perspective, we encourage that the Commission is using all resources that are available in the healthcare sector in an optimal way, so including the opportunities that are provided by innovative medicines, medical technologies, and generic and biosimilar medicines across the sectors. To the question, so how can we move together to this direction? We see a lot of initiatives in the different countries which work. So we would be interested this exchange of information between countries. What do you think is incentivizing most in member states to adopt these existing cases in their countries? What are the critical factors? Is it know about them, or, I don't know, financial incentives? What would trigger this uptake of good examples? And the second question, we would be interested to understand more in detail how the Commission want to move from this report in the area of the European semester, and especially how their stakeholders can be integrated, like represented here at PACT. Thank you.
Okay, thank you. This was kind of a mixture of statement and questions,
yes,
which is also welcome. Shall we answer, because we have several questions now coming from Susanna and then from the industry partners of the patient access partnerships. And
on the issue of lifestyle and risk factors, of course, the two have to be seen together. I mean, risk factors, obviously there are a number of known risk factors, but also some we sometimes underestimate, like, for example, the social determinants of health. But then there are choices that people make, which are, of course, in some cases, a lot depends on the choices. I mean, one has a choice whether to smoke or drink, but we have to keep in mind also that choices are not always completely free. There are going to be difficulties. I mean, we have a growing problem we have is that we see that some sectors of society have indeed a greater difficulty to make the healthy choices, because it depends on affordability, it depends on access. We talk about access to healthcare, but there's also a problem of access, for example, to affordable, healthy food, or access to exercise possibilities, depending on where you live, the infrastructure available, etc. Then there are some other lifestyle issues which other people decide for you. So basically what happens in the environmental area, it's choices other people make. So what we want to highlight here is that a lot of healthcare costs are preventable. Not all, but a great deal. And we're certainly not doing enough. Now, for me, okay, the 3% figure is always quoted, but I would not focus too much on that because it doesn't capture everything. I mean, there's a lot of prevention, for example, which is not even in health policy. Environmental policy is a prevention. Good occupational health policy is a prevention. So it's difficult to capture that within the 3%. So, but it's true, we underspend on prevention in terms of information about health, but also supporting the public. It's very easy to tell people, yes, you should have a healthier nutrition. But how are people supposed to make sense of that? How are they supposed to actually know whether they are on the right track or not? It's not so easy. So we have, I think, to look at things like mobile health, for example, and ways in which we can make this information more available. When it comes to the measurement of, I fully agree, we have to understand that when governments are, health budgets are not an end in themselves. What governments are actually paying for is not medicines or salaries of doctors and nurses. They're actually paying for outcomes. This is what they're paying for. And all the rest are important means to an end to achieve those outcomes. So the measurement of outcomes is crucial because it is how we measure the return on investment. And if we want to see health as an investment, then of course we have to be able to measure the return on the investment. Now, all of the problems the health sector has compared to other sectors is the difficulty or the complexity of health means it's more difficult to actually identify what you get in exchange for every euro invested in health. It's a bit difficult compared. And I remember the discussion some years ago was about health as a value in itself, and it certainly is. But that argument can be made for other policies as well: education, social policy, environment. And the big challenge facing governments today is how to make the trade-offs between sector and other. How much should I invest in health, knowing that there is an opportunity cost in other sectors if I don't invest enough in other sectors as well. And health has been always very weak, or rather relatively weak, in demonstrating what the return on investment is. So we have to be better at measuring outcomes. When we say outcomes, the OECD is embarking on very important work because sometimes there's also a problem in defining the outcome. We define outcomes that are not relevant for patients. And there are many examples of this. So we tend sometimes to use medical outcomes, which are not what the patient would confirm as a success. And it's very important to capture the patient perspective as well, because otherwise we will be aiming at outcomes that will not be what patients actually consider as successful. Now, the best practices, I think this is also a key issue. This should be a kind of natural thing for the EU to do. But of course, it's not a cut and paste job. And one of the aims of this exercise is basically not just to give the data, to say, oh, this is a best practice, why don't you copy it? Is to put things in context, because we cannot expect a best practice to actually be transplanted to another context if both contexts are not fully understood first. Because it's very rare that you can just copy and paste something across. You have to adapt to a different situation. And to know what aspects you need to adapt obviously means you need to know both the best practice environment and the environment in which you are trying to use that best practice in. And this is where we believe that this kind of evidence can greatly help.
Do you have something to add on that, or maybe for the other one?
I'll just pick a bit on the first comments on the, and I think the first intervention was right. We should be clearer in how we distinguish various risk factors and the notion of individual responsibility versus collective responsibility. Martin has already addressed it partly. Often it is an interaction between these two things. And it's true that in the report we focus mainly on what we call things that people could potentially modify, like physical activity, nutrition. But then it's not solely an individual responsibility, because if you're a child and you go to school, so you spend a fair bit of time in your school, but if there's no equipment or space to do any physical activity during the break at lunch or in the morning, then you're not going to do much. So there's the infrastructure has to be there. There has to be bicycle path. It has to be safe and so on. But on the other hand, we cannot deny either that there's an individual responsibility. And there's even, for children, there's even a responsibility of parents of showing the example. Because, if as parents, you're spending all your pastime in front of the computer or the television, it will not provide. So there's a mix of individual responsibility, parental responsibility, and community-wide responsibility. Now, the only exception in the chapter, which is relevant, I think, for the type of diseases that are of particular interest, is air pollution, where obviously, this is something that people are where the individual responsibility is very, very thin, and which can have big problems, obviously, for respiratory diseases.
Okay. Thank you. Now we take a few more questions from this side. Jens? Try to be shorter with the questions from the previous two questions, because otherwise we are not going to have time for everyone.
Good evening. My name is Kateřina. I work from Medicines for Europe, which represents generic, biosimilar, and value-added medicines pharmaceutical industries across Europe. I would like to thank for this interesting presentation and interesting debate. We would like to particularly focus on the health at a glance, on the section of generic medicines, where from one side we acknowledge the positive policy recommendations on the increased patient access to these medicines, as well as the inequalities of the uptake of these medicines across Europe and the potential that these medicines have to increase patient access and to have access to these treatments. However, we found a little bit antagonic, and we found a little bit disappointing as well that in the same report we have the mention and the promotion of cost containment measures such as tendering, and with the objective to have the lowest possible price on generic medicines. And we feel that in the short term we could believe that this could create savings. However, when we see in reality, in long term, promoting cost containment measures to promote excessive pressure on prices, in the end creates unsustainability and retraction from manufacturers to the markets, which leads to medicine shortages and affecting patients' health. And recently we've seen countries such as Germany and Netherlands that are actually making reforms in their tendering systems exactly to avoid this excessive pressure on prices and that ends in medicine shortages. Furthermore, another point that we would like...
Can you keep it shorter, please? Thank you.
Thank you. I promise.
No, just respect the others, so please be very specific.
We would like just to mention that we missed the opportunity to emphasize the role of biosimilar medicines as a tool to create efficiency and patient access to their treatments.
Thank you very much. So the question first and then explanation. I saw a hand there as well. No? Yes?
Hello, my name is Juan Fuertes. I am representing Pulmonary Hypertension Europe, and we are a member of the European Patients Forum. And I have a question. It's for you, Mr. SEYCHELL. You were speaking about the importance of measuring outcomes and the investment of all these tools to provide and to foster the dialogue at national level. The outcomes, I didn't hear anything that mentioned a measurement of those outcomes. How do you envisage that the progress that the countries, the member states will make with these new tools will impact and will improve the lives of the patients? And I have a second question for Mr. LaFortune, which is insisting a little bit in what Stanimir said before. When you have only one source of information, which are the member states, you risk having distorted visions of the reality. Specifically speaking, I would like to mention a case from that I got from an OECD official in Portugal last week. He was mentioning a case of success reported by the Spanish government, and it was actually a source of loss, huge financial loss for the government of Valencia and in the healthcare system. And it is being extended as a best practice among other member states to follow that model, which is to use public funds to fund public health in private hospitals, and that increases the costs by at least 12%, and is inefficient. So this the exchange of bad practices should be somehow be stopped.
Interesting concept. Thank you, Juan. We have received in advance, in written, some questions, and I think Alina is here from PICUM. Do you want to put your questions that we have in written as well? Yes.
Hola. Yes, hi, my name is Alina Smith. I work with PICUM. We're an organization that advances the rights of undocumented migrants, including in the area of healthcare. And my question picks up from what we just heard and also from what Stan was saying earlier, really about the pool from which we're gathering the evidence to make the assessment about the accessibility and so on of health systems. And I don't in any way doubt the rigor of the sources from OECD and so on, and even the member states. But of course, you can imagine from our perspective, with respect to certain population groups that are more marginalized, and we heard from Mr. Seychelles about the importance of ensuring access for the most disadvantaged groups. They're often the ones about which we have the least data. And they're often the ones, it's the hardest to grapple with the evidence, as it were. And so I just wondered about the process, really, to ensure that they are taken account of in this kind of process. We heard about 3 categories in the expert panel's report from May of this year. Undocumented migrants was one of them. Roma was another. And so just your thoughts on how we can ensure that they are included in this process so that we can really speak robustly about access.
Thank you. I think someone else also put a question in written. Is he in the room? No, but you can answer to these questions up to now. We should try to finish by 7 o'clock. We have 10.
Well, I can respond to the first question from Medicine in Europe. First, we haven't put too much emphasis in this report on the potential benefits of a greater dissemination of biosimilars, but you will be happy to hear that we will be releasing a report around the time that we have the ministerial meeting at the OECD in January, which is on improving the efficiency and reducing waste, and we will be highlighting the potential. Now, in terms of the little tension about the prices of the generic drugs, our position is that which we are expressing, is that one of the benefits of using generics is that you'll have cheaper price than brand name drugs. But then you can also you can have a sort of an additional benefit in trying to get a purchase generic as a price that is as low as possible, but without, you've talked about cases where effectively, if you put all your eggs in the same basket and the company goes bankrupt, then obviously you're shooting yourself in the foot. So it has to be a sort of a wise and sustainable. It doesn't mean trying to bring down the price to zero, so that no one will be able to produce and make some kind of a profit out of the production. But so that's it. While I have the mic, this success story that you say Someone from the OECD is mentioning in Portugal about the use of public funds to finance. We can. Like, I'm not aware of this success story. I don't think we're telling this story in this publication. I will be curious to find more about it. Then, yeah, I'll take. I think that Martin will address your other question on how to use health outcomes to improve health system performance. First, it's not completely. No, oops.
Sorry, that was not the question. The question is how to measure the benefit member states gain from this fostering of the dialogue. So if there is any progress in the end or not, and whether that progress will be made public so that they are further encouraged to actually do something.
Okay, from the dialogue, okay. Because there's all an exchange to be had, and in terms of when you're getting measure of health outcomes, on whether or not UK, in Portugal or in other countries, you are able to improve the quality of care provided. And there are many examples of progress that has been achieved. We're learning by talking to people near to us, but we're also learning from other countries' examples. So in terms of the care, we have some quality measures here are about the care for patients who are going to a hospital with a heart attack or a stroke. And there have been some countries that have developed system that improves greatly your chance, not only of surviving, but of surviving in a much better health state than in other hospitals in your country or in other countries. So there's a lot to be gained from finding out more in terms of mortality, but increasingly also in terms of the quality of life of people after different intervention for different types of cancer or whatever. Or even there was a dialogue on avoidable morbidity, on avoidable hospitalization, which is a big issue, how to deal with chronic diseases so that people with asthma, diabetes, hypertension, and don't end up in hospital. And we're seeing that there's wide variation. But then we don't have all the explanations. So at some point you need, and there can be as much variations within the regions in your country or across hospitals in your country as they are across countries. So it's a sort of a diagnostic, a sort of a high opener. The publication does not provide all the answers. It's only through discussion, between within the country, across countries, that you can go a bit deeper and find out solutions to some of these problems.
I mean, the measurement of outcomes is indeed key to improving performance and improving also benefit for patients and ultimately for health systems. But there are two important preconditions for that. First of all, the outcome measurement has to be done in a standardized, comparable way. If we are comparing apples and pears, it's very difficult to make heads or tails of that and learn from the process. So that's, I think, the first hurdle that has to be overcome. And I know the OECD is working on that. We will fully support that work because, first of all, we have to establish a yardstick. Not for the sake of saying who is better than whoever else. I mean, that's not the point because every member state has success stories and every member state has areas that need improvement. It's clear from even the few graphs that we saw today. But we need to be able to standardize the measurement. Second condition is that we also need to capture the perspective of the patient in the measurement. And this is where very often historically there has been kind of difference of opinion. And because if we measure outcomes in an abstract way without taking into perspective that ultimately that outcome has to be something which the patient feels is a positive outcome, then of course there will not be a real improvement in the public perception of health systems. Health systems have that important function as well. So I would single out these two elements. So the use of outcomes, I think in the health sector is still lagging behind what other sectors are able to do when they link investment with results. And if we really want to move to health as an investment, we have to be able to measure the outcomes. Otherwise, it's difficult. I mean, when we talk about prices, for example, a price, of course, is an important factor, but it does not exist in a vacuum. The other side of the equation is what do you get in exchange for what you invest in a pharmaceutical, in a medical technology, in specific salaries that you pay for specific categories of specialists or professionals. It's difficult to know whether you are on the right track or not, whether you are over-investing or under-investing, if you do not also compare what you are investing with the outcome. So it's crucial. And indeed, I think we have to move away from looking at the health budget, at the health expenditure as just a big procurement budget, to an outcome-based budget, where, of course, it will mean that national governments will specify the outcomes, the targets. This is their role, like they do in other sectors. But of course, you need a tool for measurement. Otherwise, we are just discussing abstract concepts forever.
Last few questions I will pick up, Robert, and then you try to keep short so we finish on time.
Yes, my name is Robert Johnston. I'm on the board of the European Patients Forum. I have a chronic condition myself, which I've lived with for 60 years. I'd just like to pick up what Martin was saying at the end there about looking at the outcomes through the patient's eyes, because this is what's going to make the difference in the individual countries. If you engage the patients in this process, if you empower them with more information, more recognition as part of the system, stop seeing us living with chronic conditions as being the problem, start to see us as part of the solution, and then you will be able to achieve much more effective change within the national member states, but also across Europe. Cross-border healthcare hasn't worked except for some minor areas where the borders are very close, because people don't feel that they can perceive a big difference from going somewhere else to get treatment. Involve us, give us more information, give us more power, and we will help cause the changes at national level as well as at European level. Thank you.
Good evening. I'm Francesca Kateřina from the European Consumer Organization. I just like to thank the OECD and the Commission for this report. We think that it puts forward some very good recommendations. And building on what the comments that have been made, and especially with the answer that you, Martin, has given, I would like to say that we hope that the next report will keep on focusing on these elements, the element that it already takes into account, before engaging in this new narrative that the industry is putting forward, which is the outcome-based approach, at least before some crucial aspects that you have been mentioning will be resolved. Thanks.
Some last burning question before we give the floor for this. Okay. Will you answer to the last two questions?
Yes, before, because I didn't, I forgot to answer about a very important issue relating to access, of course, which is the disadvantaged groups or vulnerable groups. And this is, I think, has to be an increased focus for our attention, in the months and years to come, because it's clear that we are seeing big changes in that regard. There are, of course, some disadvantaged groups that are still with us since a long time. They were disadvantaged and they still are disadvantaged. And those we need to really address. But there are also some new disadvantaged groups. You mentioned the undocumented migrants. There are others as well. We have the long-term unemployed, other categories. And I think one of the aims of this exercise will be to acknowledge that there will be data gaps, and we will need to see what is the best way to address, to gain specific knowledge. Because without specific knowledge,
debate also to go on national level. We would encourage also the institutions to take on board the stakeholders' perspective, the patient's perspective, the other stakeholders when you're preparing these very important documents, I believe, especially the country-specific work that you do, because at the end the things happen in those countries and the people live in those countries and the patients are there, not here in Brussels. So very much welcome that. And at the end, I would like to give the floor to Mr. Kovatchev to say a few closing words. Thank you very much for making, again, this meeting possible for the stakeholders and for our fantastic speakers today. Mr. Kovatchev.
Thank you, Stanimir, and thank you very much to the speakers, Mr. SEYCHELL and Mr. LAFORTUNE, for being here. And exactly this is the mean of our group in the European Parliament, of access to give a platform to you, to all stakeholders in the health sector, and to discuss what the European Union can do more for the European patients, because the Commission is often criticized that it's doing not so much on the limited possibility what the European institution has in this sector, and primary responsibility is in the member states, and some of the member states are very insisting that this is staying with the member states, and that the European institutions are not so much involved in the legislation. But not only legislation in this sector is so important. I think we can, the 2 points what Mr. SEYCHELL mentioned, better measure of outcome, standardized measure of outcome, and exchange of best practices. This is key points which we can, together with the stakeholders here, follow. And indeed, what Mr. Hasarjev also mentioned, you need to be consulted before each step done, either here by the European institutions or by the member states. I welcome very much this new initiative of the Commission, and looking forward to work with you, with all of you, with all stakeholders in the health sector. And you can be sure our group here in the European Parliament will continue to support all initiatives which bring more value, more European value to the health policies in Europe. Thank you very much.
Thank you. And at the very end, to tell you that the presentation that you just saw would be uploaded to the PACT web page, so you can go to the PACT web page and download it from there, and know more about the small graphics that you couldn't see on the big screens behind. Thank you, everyone, and have a good evening.